Today we'll be discussing one more very interesting ECG. So this is an ECG of a patient who presented to our hospital with chest pain. Now, whenever any patient is presenting with chest pain, one of the most important things we always have to think is about myocardial infarction, means heart attack. So in myocardial infarction, basically we can have few things like the most important thing for in myocardial infarction is basically whether it is ST elevation or ST depression. So whenever we are thinking about MI or myocardial infarction, it has to be either ST elevation MI or it can be non-ST elevation MI. So we call it as STEMI and we call it as non-STEMI. So usually STEMI, the treatment thrombolysis can be given, PAMI can be done, but in NSTEMI, usually thrombolysis is not done because we are not actually sure whether it is an ischemic process. Whenever there is clear-cut ST elevation, we definitely have both the options of thrombolysis as well as PAMI. But in ST elevation, we can always go non-ST elevation MI. We can always go for PAMI. We can directly take the patient to the cath lab and we can explore the culprit vessel, and if it is blocked there, then we can go for plasty at the same time, but we cannot thrombolize that patient. So that is one problem. So one of the most important thing, whether to means any patient when the patient is presenting with chest pain, we have to consider it as ACS. So ACS is comprised of three things. Either the first thing is MI, that is STEMI, ST elevation MI. Second is non-ST elevation MI, and third is an unstable angina. So I'll tell these things in very simple language to understand. So any patient presenting with chest pain, we for ST elevation, patient must have ST elevation, and in such patients, you will get positive cardiac biomarkers like TROP-T and CKMB or TROP-I. These things will be positive. So there will be both ST elevation as well as positive cardiac biomarkers. This positive cardiac biomarkers may not be present at the time of admission. In the first few hours, the troponin T, troponin I can be negative, but when we repeat the troponin I and troponin T, after 6 to 8 hours, they usually turn always positive if it is ST elevation MI. Same with non-ST MI. Here the cardiac biomarkers will be positive. So there will be positive TROP-T or TROP-I or CKMB, but there will not be ST elevation. That is the reason why it is called NSTEMI. And the third one is unstable angina. So unstable angina is third because there will not be ST elevation for sure, but the patient may have some ST depression changes or T wave inversion changes, which usually suggests that patient may have ischemic heart disease, and patient may typically present with chest pain that may radiate to left side of the arm, right side of the arm, that may radiate to jaw, or patient may complain of shortness of breath or palpitations. These are also called angina equivalent. Means these are patient may not need to say chest pain always. In fact, shortness of breath, palpitation, breathlessness, these symptoms are as equal or as good as chest pain itself. And in unstable angina, you'll not be having this cardiac biomarkers positive. So in unstable angina, there will be negative cardiac biomarkers. So this is in short the categorization of ACS or acute coronary syndrome. So in this patient, what we can clearly see, we can very clearly make out this P wave. The P wave is present. It is positive almost everywhere. There is no inverted P wave, or it is not very wide. It is not more than 2.5 small boxes. It is almost equal to two small boxes. And actually, abnormal P wave we call if it is more than 2.5 small boxes, or if it is more than 2.5 small boxes. in height. So it has to be either more than 2.5 millimeter in height or more than 2.5 millimeter in width, and that could be bifid as well. If that is the scenario, then we call this as an abnormal P wave. In this scenario, it doesn't look like, though P is slightly bifid, we can see that P is slightly bifid, but it is not more than 2.5. So it's almost two small boxes. So the next thing that we need to say is QRS complexes. So in this, we can very nicely make out very upright QRS complexes. So here on the QRS complexes, we can make out very, very well. And one of the most important thing for any person presenting with chest pain is always ST elevation. We have to have ST elevation, either it could be elevation or it could be ST depression, or there can be marked T wave inversion. T wave inversion. These are the things which we always need to see. So normally T wave is a positive wave in chest leads, usually in limb leads. But if it is markedly negative, then or if it is a new onset wave inversion, suppose you do first ECG, maybe yesterday's ECG or day before yesterday's ECGs, or maybe 1 week back, 1 month back, if you compare the ECG of the same patient, and if you find that earlier the T wave was positive and this time the T wave is negative, it may mean that patient currently presenting with chest pain may have an ischemic heart disease or may be having impending block of the coronary arteries. So we always have to see basically the ST elevation, ST depression, and to say ST elevation or depression, we should define the baseline. So this is the baseline. This is the running baseline basically. So this is the running baseline. So when you see this line is a baseline. So this is the baseline. So if we see here, this is the running baseline. So we can trace the same line all the way. So this is the baseline. The P wave where it starts, this is the baseline. So we can very clearly make sure that here there is depression of the ST segment. It is almost dropped by 1 millimeter. If we can see it here as well, the ST depression, there is more than 1 millimeter ST depression. There is clear cut ST depression in lead 2, lead 3, lead AVF. These are the inferior leads. As I have told these things earlier also, lead 2, 3, AVF. These are for inferior or posterior wall of heart. So we are having this ST depression in lead AVF, in lead 2. What are the other findings are the when we see lead V1, V2, we can very nicely make out an inverted V2, inverted T inversion in V2. In V1 also it is subtle, but usually what we say, if QRS is negative, then T can be also negative. So here QRS is positive, and in spite of that, we are having inverted T wave. In lead V3, what we can see, there is marked ST depression. So this is the baseline, and we can very nicely make out that ST is downsloping. ST is downsloping. ST segment is downsloping, and the T is inverted. So inverted T and downsloping ST is very highly suggestive of ischemic heart disease, very highly suggestive of block in coronary arteries. So here also, this is the baseline. We can very nicely make out the marked ST depression that is going towards the downside obliquely, and there is marked T inversion as well. So there is marked ST depression in V3, V4, V5 as well as in V6, which is very, very characteristic feature of ischemic heart disease. Now this type of pattern can be seen in two things. First is in ACS. So as there is no ST elevation, and if patient is presenting in with chest pain and ST depression and positive cardiac biomarkers, we will be labeling this as NSTEMI, non-ST elevation MI. And if cardiac biomarkers are positive, if chest pain is there, then we can simply call this as a strain pattern. This is called strain pattern. Now, what is strain pattern is those patients who are known case of high blood pressure, those patients who have hypertension, but it is not well controlled, or those patients who got diagnosed with hypertension much later. So before getting diagnosed, such patients already develop some irreversible changes in the heart, because we know high blood pressure, increased blood pressure means heart has to pump against such high blood pressure. So if heart has to pump against the high blood pressure, to pump and to keep up with the high blood pressure, heart has to increase in the size. So it has to undergo hypertrophy. So heart will be simply hypertrophied. So whenever we have hypertrophy of the heart, there will be always a concentric hypertrophy. Concentric means the heart will get increased in size from all around the uh, heart. Means it will not be only in this part or this part or this part. The selective hypertrophy of the muscle is very commonly found in HOCM. So there can be selective hypertrophy of interventricular septum, but that is a very much common feature of HOCM. But in hypertensive hypertrophy, there will be concentric. So there will be significantly increased muscle mass of the left ventricle, and we call it as a concentric hypertrophy. So if heart is this much tense, if heart is this much hypertrophied, one of the most important thing of diastole is in diastole, the heart has to get relaxed in this direction. So to receive the blood, heart has to get into relaxed mode. Just imagine that there was an earlier heart which was very normal, which was not that much hypertrophied. So it could easily relax in all direction. But now heart has hypertrophied. So if this heart want to relax, if this heart has to go into diastole and receive more blood, whenever it will go, whenever it will try to go this side, means this downside, this muscles present here will not let it go there because these are hypertrophied. This is significantly stiff. This is hypertrophied muscle, this here. So when this muscle has to go here to relax so that more blood can come in, this part of heart muscle won't let it do it because this is very much stiff. So in short, heart can't go into diastole very well. So heart can't relax. This is the reason why the diastolic pressure increases significantly. And this diastolic pressure is simply transferred to left atrium, and the left atrial high diastolic pressure is transmitted to lungs, to the pulmonary vasculature. And this is the reason why patients perceive shortness of breath, breathlessness, even in very minor physical activities. So shortness of breath even on minimal activities, which we call it as a NIHA grading. We can label like NIHA grading 3 or 4, because later these patients develop shortness of breath even on very minor physical activities. So if a patient is presenting with a downsloping ST depression, T inversion, and this if this can be definitely one of the most important thing is it can be STEMI if cardiac biomarkers are positive like troponin T, troponin I, or CPKMB. Second, it can be very typical of a strain pattern. Strain pattern means because the chronic hypertrophy, because of the chronic concentric hypertrophy, usually patients will present with the same ECG again and again. Means even patient may not have any symptom at that particular point of time, but his ECG will show these changes. So you repeat his ECG, you recheck his ECG after 1 month, before 1 month, 2 months, and that time also the patient may have almost the same ECG. So such changes are very, very typical in NSTEMI and strain pattern. So I hope you understood everything very well. If you have any queries, you can please let me know. And thank you for today's class.